Okay, so good morning, good afternoon, good evening, everyone joining this webinar. We are from King Khalid Eye Specialist Hospital, and we are presenting the Global Education Forum. I'm so glad to present four of our top-notch speakers who will present or speak about the ITRACK canaloplasty and the ABIC procedure. ABIC refers to the ab-interno canaloplasty, which is one of the mixed procedures that allow catheterizing and also vasodilating all the aspects of the outflow resistance. And here I'm speaking about the trabecular meshwork, the SCHLEMM'S canal, and also the, the distal outflow system, beginning with the collector channels. So till now, we consider ABIC as the only MIGS procedure that addresses the blockage at the collector channels. Without further ado, I will start presenting our first speaker. We have Dr. Mohmoud Khaimi. He's a clinical professor and director of glaucoma fellowship at prestigious Dane McGee Institute, University of Oklahoma. Dr. Khaimi has numerous publications, book chapters, and he's the editor of Essentials of Glaucoma book. And he's also the innovator and pioneer of the ITRACK ABIC procedure. He's well-known national and international speaker, and we were honored by having him as a visiting professor to KCASH on April 2018, at which he shared his experience in ITRACK ABIC procedure. So with that being said, please join me to welcome Dr. Khaimi. Dr. Khaimi, please, you can start sharing your presentation.
Okay, thank you, Dr. Ahud, for a very generous introduction. Can you guys hear me, and are we all good? Okay,
yes.
Great.
Yeah.
Yeah, it's a pleasure to be with my KCASH colleagues. I have very fond memories of that visit in 2018. So it's really an honor and a pleasure to be with you guys again. So I've been given a 20-minute task to kind of give you guys an idea about canal-based glaucoma surgery. And so we'll get started on that. So let's hopefully not have any glitches. So ITRACK canal-based glaucoma surgery can be performed via both ab-interno and ab-externo approaches. And it has been shown to increase the aqueous outflow through the conventional outflow pathway that starts off at the trabecular meshwork, SCHLEMM'S canal, and distal collector channels to deliver sustained reduction in intraocular pressure and medication burden. So I'd like to do a little bit of a timeline here on how this all evolved. And in 2004, Dr. Stegman did the first traditional ab-externo canaloplasty procedure. And in 2005, Lewis et al. Had a 3-year multi-center ab-externo study that started. And in 2008, iScience Interventional in the United States took on the ITRACK technology and commercialized the ITRACK. 2011, the 3-year multi-center study by Lewis et al. Was published. And in 2014, Alex Medical out of Australia acquired the ITRACK technology from iScience Interventional. Also in that year, in 2014, I developed the ab-interno approach to canaloplasty. And in 2018, a dear friend and colleague of mine, Dr. Mark Yardo, published his 12-month data on ABIC using the ITRACK catheter. The genesis for ab-interno ITRACK basically stemmed from a study that I did. I published a large case series for traditional canaloplasty, and we looked at, we actually looked at those eyes that did not have a proline suture. So we couldn't get around 360 degrees, and we only viscodilated those eyes. And as you can see, these eyes 3 years out actually looked really well, did really well from an intraocular pressure lowering standpoint, as well as a medication burden standpoint. So that was the genesis for, and at the time we started doing more ab-interno approaches. The iStent had come out. And for us that do pediatric glaucoma, we've done ab-interno goniotomies on these kids. So we're familiar with the ab-interno approach, and so one thing led to another, and we developed ITRACK ab-interno canaloplasty. So why does ITRACK make sense? In order to answer that question, we really need to look at the anatomy and see what's going on. So Schlemm's canal is a circular canal in the eye that collects aqueous from the anterior chamber and delivers it to the bloodstream via the anterior ciliary veins. Increasing IOP, we know, leads to a progressive collapse of Schlemm's canal. And as Schlemm's canal collapses, the active flow areas decrease. So here's a diagram of the distal outflow system. And you can see Schlemm's canal connected to the intrascleral venous plexus that then drains through the aqueous veins to the episcleral venous system. And if we look a little bit closer on this, the collector channels and the aqueous veins, if we look a little bit more into that, the collector channels, we've got about 7 to 11 what we call supercollector channels. They have an 80 to 100 micron diameter openings. There's about 2 to 3 of them in each quadrant. There's about 20 to 30 microcollector channels that have a smaller diameter, 10 to 70 micron diameter opening. And we know that there's evidence of fewer patent collectors with age and disease. Of course, the aqueous veins provide the back pressure for flow control from the episcleral venous pressure. Dr. Gong had a very elegant study that basically showed and demonstrated that 61% of collector channel osseous were blocked in open angle glaucoma patients as compared to 14% of normal eyes. So there was significantly more herniations into the collector channel ossea in open angle glaucoma patients than normal eyes. And if you take a look at this, about half of the herniations were complete herniations. So that is good to know and understand what's going on with our open angle glaucoma patients. So here is a normal collector channel that's open, and here's a collector channel that is partially obstructed, and here's a collector channel that has basically herniation of tissue into it, and so it's completely obstructed. So Paul Kaufman et al. Also showed that with viscodilation of canal, one can see fractured trabecular platelets in the adjacent areas to viscodilation. So with the ITRACK, it delivers a precise volume of OVD via very pressurized viscodilation system into Schlemm's canal. And this dilates the canal with possible creations of these microfractures and focal disruptions within the trabecular beams. And so this is why we say it starts at the trabecular meshwork and works all the way to collector channels distally. So there's focal disruption that could help decrease the outflow resistance. And this is a big deal here when we're talking about the outflow system. What else do we know about the outflow pathway? Well, we know that as one ages, normally there's a decrease in TM cellularity with aging, but this happens at a faster rate in folks with open angle glaucoma patients. We also know that there is an increase in extracellular matrix in the juxtacanalicular trabecular meshwork in patients with open angle glaucoma. So you can see all the resistance to outflow due to the deposition of ECM here. And I want to pay attention to the vacuoles here. And here's Schlemm's canal, because the vacuoles, what happens to these giant vacuoles that aid in transporting aqueous from trabecular meshwork into Schlemm's canal. Well, as you see here, here's the vacuoles on this scanning electron microscope. And as the disease severity increases, as we go downward here in this pictorial, you'll see that there is a decrease in giant vacuoles and pores of the inner wall endothelial cells of Schlemm's canal. So we have a decrease in giant vacuoles, and there's a decrease in pores, which leads to, in glaucoma patients, which leads to an increase in resistance of outflow. This then leads to an increase in intraocular pressure, which we know leads to herniations of TM into Schlemm's canal and collector channels, and then the intraocular pressure continues to rise. We also know through other studies that the collector channels are not evenly distributed, and that outflow is segmental. And the biggest issue is that we really don't know where the site of resistance is. It's not clearly known, and it's variable in individuals. And so it would make sense to have a procedure that would comprehensively address all areas of potential outflow resistance, starting from the trabecular meshwork down to the distal collector channels. For patient selection, usually, I've juxtaposed this with the traditional glaucoma procedure, ITRACK procedure, AB-INTERNO. I'll just be talking about AB-INTERNO. And so usually for early to moderate open angle glaucoma patients, although we've used it on all severity folks with open angle glaucoma, the majority is for early to moderate patients. The nice thing about this procedure is atraumatic and it's tissue sparing, minimally invasive glaucoma surgery. So, and it can be it can actually be performed on both phakic and pseudo-phakic patients. So say for example, you want to reduce the pressure in a patient who has open angle glaucoma. Eye stent is widespread now, so perhaps a patient has already had an eye stent procedure. Their pressure is still up. They're uncontrolled. You can do this procedure on those patients, or you have a patient who has uncontrolled open angle glaucoma on multiple drops. This procedure can be performed on those patients. You can also perform this procedure on patients that you would like to attain a reduction in their medication burden. That's a big deal nowadays, the quality of life measures, and patients that have difficulty with taking drops for multiple reasons. And so control patients with prior mixed procedures or eye stent, you can do that on those patients. Again, you can do it on control patients that have, sometimes patients don't even want to take one drop, and you can do that on those patients. Patients, of course, with dry eyes that are symptomatic, the last thing you want to do is add to their dry eye issue because they have a lot of complaints. And so, of course, we know that there's some toxicity with the glaucoma drops, and that can exacerbate their dry or ocular surface disease. And so to decrease that burden, you can do this procedure. Of course, non-compliant patients, and of course, the active and the young patients that I don't know about you guys, but in my practice, a lot of patients are coming with the wherewithal of, potential side effects of glaucoma procedures. And, I'll have young patients or very active patients tell me that I don't want to be subjected to a trabeculectomy and a lifetime risk of infection or complications due to the bleb. And so quality of life measures, to preserve quality of life measures, I think this procedure does that very well. So what's the mechanism of action of AB-INTERNO ITRACK? So there's a mechanical effect. So the circumnavigation of the ITRACK microcatheter through Schlemm's canal creates this mechanical effect where it breaks the adhesions in canal, breaks the tethering of juxtacanalicular trabecular meshwork. It also separates herniations in the inner wall of Schlemm's canal from the outer wall, and it creates these focal disruptions within trabecular meshwork that we pointed out on another slide previously. So in addition to that, there's the viscodilation effect. And so there's a precise amount of viscoelastic that's released through the ITRACK catheter, and that's delivered into Schlemm's canal during this whole process. And it's pressurized, so it comes out with quite a bit of pressure. And this in itself dilates Schlemm's canal. It may also dilate the distal outflow system. And I also believe that there's a chemodilatory effect here, that once Schlemm's canal is open, there is a cascade of factors that might be released to maintain patency, much like a dilation or pressure on vasculature would release nitric oxide, perhaps. So ITRACK definitely comprehensively addresses many areas of the outflow resistance. So it treats the trabecular meshwork, Schlemm's canal, and the collector channels. it's a comprehensive procedure as compared to other mixed procedures that basically comprise a single point stent that bypasses or even penetrates or ablates trabecular meshwork. So we're treating the whole system as opposed to one particular area. And it opens the distal outflow system behind the trabecular meshwork, hopefully ensuring that there's better aqueous outflow. The nice thing about the ITRACK canaloplasty is that it does not preclude further treatment options. So you don't burn your bridges here. It's a very atraumatic procedure. So you can do other future treatment options if you want. It doesn't keep you from doing that because simply it doesn't ablate or remove tissue. It is effective as a standalone or adjunct procedure to cataract surgery. So in the United States, we can, some of the MIGs are bound by having to do cataract surgery at the same time, but in the United States, we can perform this procedure on phakic and pseudophakic patients, so not having to include it with cataract surgery, although it's oftenly performed with cataract surgery. So a closer look into the ITRACK surgical system. There's an illuminated tip here that allows this second by second feedback of where you're at. In other words, you put it in canal and you want to stay in canal, and it shows you if you're in canal or not. So it's very important. There's an internal guide wire that helps guide the ITRACK through SCHLEMM'S canal. It has that structural integrity to be able to pass through canal, even a stenotic canal, it can get through that. It has this round bolus tip that produces or allows for the reduction of trauma during catheterization and limits misdirection into collector channels. And of course, the viscoelastic injector that's connected to the end of the ITRACK catheter that allows for the precise delivery of viscoelastic under pressure. This ITRACK catheter is then connected to a eye lumen that gives the lighting source. And of course, there's really no capital equipment with this procedure. It's the ITRACK and the eye lumen that allows you to be able to have the light source. Here's a closer look. Of course, there's the round bolus tip, the internal guided wire here, and through this comes out the viscoelastic that's injected into canal. We'll take a look at the procedure itself right now from start to finish. This is Mohmoud Khaimi from the Dean McGee Eye Institute, University of Oklahoma. We're going to look at ITRACK ab-INTERNO canaloplasty known as ABIC. First step is to create a paracentesis a couple of clock hours from the future otomy site. Viscoelastic is then placed into the anterior chamber to hyperpressurize the AC. And you can see me priming the ITRACK catheter right now, and you can see how much OVD is expressed onto the cornea. The ITRACK is then placed into the anterior chamber and then secured to the patient's forehead or close to the nasal bridge. The patient's head is also tilted away from me, and you can see that I'm tilting the scope towards me in typical angle-based surgery fashion. This allows us to get a good view of the angle, especially using a gonio prism that's floated over the cornea. 27 gauge half-inch needle is then used to slightly score over anterior trabecular meshwork. And you saw how I pulled down a little bit on TM to expose SCHLEMM'S canal. And MST forceps are then used to guide the ITRACK catheter into canal, either from the external approach or internal approach, as you see there. You can see the lit tip kind of coming around 360 degrees, letting you know where it's at all times. Here you can see that it's come all the way around 360 degrees. The lit tip again shows you where you're at. And it's at this point that I will retract the catheter. And as I begin to retract the catheter, I will then ask my scrub tech to start clicking on the viscoelastic injector. And you can see that clearly there. Every time there's 1/8 of a revolution on that viscoelastic injector, it will express viscoelastic into SCHLEMM'S canal, which is then forced anteriorly through TM and posteriorly through SCHLEMM'S canal and into the collector channel. With one continuous smooth motion, the ITRACK catheter is retracted completely out, the patient's head is tilted back towards me, and the OVD that was placed into the anterior chamber is removed with the irrigation aspiration hand. So that in a nutshell was the procedure. And so I'm very excited to also present our 3-year follow-up of AB-INTERNO ITRACK in patients with open-angle glaucoma. So at the Dean McGee Eye Institute, we did a non-randomized single academic center-based study that retrospectively reviewed the surgical outcomes of ITRACK phaco and ITRACK alone performed by 2 attending physicians, 4 fellows, and 22 residents. So we included everything, even fellows and residents, in our data collection. Of course, we looked at typical baseline demographic information, preoperative diagnosis, disease burden, etc. This data was recently presented at ASCRS and the World Ophthalmology Congress virtual meetings. In a nutshell, this is the demographics for the study. And due to time constraints, I'm not going to go too deep into this, but I do want to point out that we actually truly looked at real disease here. The phaco ABIC patients, 594 of those patients had a mean deviation of -7.5 decibels on their Humphrey visual field, and of 275 patients that just had ABIC, they also had true disease of -8.8 decibels on their mean deviation and on visual fields. So again, the vast majority of these patients had mild to moderate disease, but there's approximately 20 to 25% that had severe disease. If we take a look at the IOP reduction of all comers, we're just about at 3 years, 21% reduction in intraocular pressure of both groups. But if we look at the medication burden at 3 years, there's just under 50% in the ITRACK phaco and about 30+% in the ITRACK alone. When we further stratified this data, a lot of patients ask me, can ITRACK be used on patients that have high intraocular pressures to begin with? And here I want to point out this stratification was for patients that had a pressure of over 22 to begin with and over 25. So essentially in the over 22 category, their mean IOP was 27, and baseline IOP for the folks that fell in the 25 or higher group was at almost 31 intraocular pressure. And so when we looked at the reduction of intraocular pressure here at 6 months, starting at 40% and 47% with the ITRACK phaco group, and down to about 32 to 38% in the ITRACK alone, you can see the numbers are substantial reduction here in mean IOP as time goes along. So these were patients that were uncontrolled, had very aggressive glaucoma, yet here at 2 years out, we're able to drop the pressure by just under 40% in the phaco ITRACK group and about 40% in the ITRACK alone group. So that's pretty meaningful. Medication reduction burden, of course, we saw a dramatic drop in medication burden at 6 months. We also saw that at 12 months and at 24 months in all groups here. So complications and safety profile for AB-INTERNO ITRACK, you know, it's a very, very safe procedure. We had 800 plus patients, about 92% remained free of adverse events. The most common adverse event was a post-op IOP elevation at 1 week that was greater or equal to 30. This happened in about 8 to 10% of folks. However, only 0.3% of folks, only 2 from the ITRACK phaco group required additional surgery to address this intraocular pressure. In other words, that IOP spike was transient and was not sustained, and medications or just watching the patients resolved the matter. No Descemet detachments were observed, and we didn't have to do any hyphema washouts. A question I'm often asked, well, how many patients after ITRACK have to go on to surgery, other more invasive glaucoma surgery? And so of the 859 patients 3 years out, only 6% of the phaco ABIC patients went on to have more surgery, and only 14% of the ABIC patients required additional glaucoma surgery to control their disease process. And this was in the form of either trabeculectomy, glaucoma drainage implants, CPC, etc. We do see this trend for intraocular pressure to go up a little bit postoperatively. This elevation in intraocular pressure is not uncommon with MIGS in general. And it's also seen with ITRACK. This can be avoided with minimal use of low-dose steroids, 4 times a day for 3 to 5 days, and then reduced to 1 time a day for 3 days. So it's a very fast taper. This is a minimally invasive procedure, and so the eye is really quiet afterwards. And of course, if the pressure goes up, this can be treated at the discretion of physicians, starting off with aqueous suppressants. Aqueous suppressants tend to be more successful than the prostaglandins here for postoperative measures. I do not restart the glaucoma drops to begin with. I want to see what kind of pressures we're dealing with. And then if I need to, I'll add drops afterwards. So in summary, ITRACK canal-based glaucoma surgery does not remove or ablate tissue. It does not implant any devices. It's literally less invasive than cataract surgery, and it preserves future treatment options, which is important when you treat a glaucoma patient. We don't have a curative procedure, so we're always looking to what we can do next, and we don't want to burn our bridges. It's suitable for phakic and pseudophakic patients, suitable for mild to moderate patients, and it's very effective in lowering intraocular pressure and decreasing medication burden as exhibited by our study. I want to thank everybody for their time, and I believe we'll be taking questions afterwards.
Thank you so much, Dr. Khaimi. That was excellent presentation and very intriguing information. So I'll just go directly to, I'm trying to be the bad cop here. So I'll just go and ask you about how do you compare the ABIC to GATT procedure? You know, we had Dr. Grover here in one of our webinars, and you know that he's one of the, pioneers in GATT procedure. And we had a long debate about how to compare ABIC to GATT. So I would like to hear from you.
Yeah, I mean, I think GATT is a very effective procedure. My only issue with the GATT procedure, it's pretty destructive. And there are some ramifications from doing a 360-degree otomy, i.e. hyphema, recurrent hyphema. The eye undergoes more inflammation. There's even case series that show a dilated pupil after these procedures. So in showing what I showed and the results that I showed with AB-INTERNO canaloplasty using the ITRACK, which effectively works on the trabecular meshwork. So in other words, we have somewhat like a GATT procedure, but we don't have to really rip through the tissue because we saw the platelet formation in the trabecular meshwork. If we're able to accomplish that and viscodilate SCHLEMM'S canal and the collector channels without having to destroy tissue, in my opinion, then I pose the question, why is it that we then need to, in essence, pull through TM if we're getting such great results with just viscodilating and preserving tissue? The other issue that I have is if we're getting these results with iTrack canaloplasty, of course, this is the center of attraction now for glaucoma treatment, basically going back to the outflow. And in my opinion, now the outflow or the angle, the tissues of the angle, we should treat it just as cautiously as we treated the conjunctiva. The conjunctiva was the holy grail. We didn't want to mess with the conjunctiva. We wanted to preserve it because if we had bad conjunctiva, we basically couldn't do our trabeculectomy or our tube implants because that was our only form of treatment. Well, I'm saying the same thing now for our outflow system, our angles. As we get to learn more about this, if we've destroyed the tissue from the get-go, then perhaps when we have drug delivery, which we're already starting to do now with topical medications that is actually directed at the outflow system, or we have drug delivery down the road, if we've destroyed that tissue, we really can't treat those patients with those modalities. So that is where I kind of stand with the whole ITRACK ABIC/GATT debate. I don't doubt that GATT works, and I think Davender and Grover et al. And a lot of folks have showed that it's effective. But here we are showing a less traumatic procedure that is just as effective.
By the way, I'm not an advocate of GATT or any other mixed procedure. I'm just trying to, you know,
well, I think
to
it's a great question.
these procedures. Yeah, and I just like to hear from you your perspective of GATT procedure. Would you like to comment, Dr. Konrad?
I totally agree with what Dr. Khaimi has said. I think that if you can avoid destruction, inflammation, it's an earlier step. I also will say that the GATT has the steps and the position, and probably one of the indications I see is in all those conditions in which there is an anomaly in the Schlemm canal. But I think ABIC is more conservative of the structure, and that at the end is going to be good. And I'm really impressed with the result of that last paper you have shown, Dr. Khaimi. It's amazing the number and the 3 years of follow-up. It's really given us the final push to keep doing this technique.
Yeah, thank you. I mean, we're the study actually. One thing that I kind of want to remind folks is we included resident data and fellow data. Typically, when you want to produce a study or publish a study, you hide their data. You don't want to show resident and fellow data, but we wanted to show folks that you know, it's still effective in the hands of residents and fellows. Of course, we have phenomenal fellows and residents here, as KCAS does also. But you know, it was all inclusive. It just was all inclusive, and so I think that was also very impactful.
So, Dr. Khaimi, with all those, you know, viscoelastic material inside the canal, how would you leave the pressure at the end of your procedure? Would you aim for a high pressure or just normal or low pressure?
Yeah, very good question. So I want to point out one thing here. Viscoelastic anterior to trabecular meshwork is what causes your pressure spikes. Okay. A lot of folks say, well, you're putting all this viscoelastic in the Schlemm's canal. How in the world don't you have intraocular spikes afterwards? And do you have to worry about that? It's the viscoelastic that's actually in front of TM that can cause postoperative IOP spikes. And so you have to do a very good aspiration and irrigation or irrigation and aspiration, excuse me, so that you can remove that viscoelastic. Remember that viscoelastic is being pressurized and pushed through. So it's not just sitting in Schlemm's canal, it's going out through the collector distal channel. And you can see that on episcleral venous blanching on the table. So it's pretty remarkable. I tend to leave the pressure of the eye normal to just a little bit higher, because no matter what, you might get a little bit of regurg of blood into the AC, especially if you see a little bit of regurg of blood at the time of surgery. So I may leave it normal to high normal. I certainly don't leave it hypotenuse, and I certainly don't leave it very high, nor do I fill the anterior chamber with viscoelastic at the end of the case to prevent a hyphema, because hyphemas tend to be very small after this procedure. Because we're not ripping through tissue, as you recall. So typically the common scenario is microhyphema afterwards, and sometimes we'll see some layered hyphemas that are very minimal.
Okay, one of the attendees here is asking, how many notches are you providing per quadrant?
Yeah, I think,
how many notches you recommend?
Yeah, so how many times do we click on the viscoelastic injector? Typically, you know, I think it depends on how comfortable you are with the procedure. So for a beginner, once you have once you're familiar with how to pull the eye tract out of the eye, and you're in synchrony with your surgical scrub who is clicking on the viscoelastic injector, as you saw in the video, typically I would say probably 30 to about 50 clicks. I would stick with the 30 as a beginner, just so that you can get accustomed to the procedure. You want to have one continuous movement of pulling the eye tract out. In other words, you don't want to stop at one area and have the surgical scrub continue to viscodilate, because this is where you get into trouble and you can have your decimate detachment. Only if you're in that, you're stopped and the viscoelastic injector is still clicking and you're getting over zealous viscodilation in one area. So I would say for beginners, if you can stick with 30 to 35, as you get more comfortable, you can go from 40 to 50. And typically this is where you should be. Now, once you get back to half or subincisional, about 180 degrees, if let's say your goal was to click 30, you should have clicked about 15 times by subincisional, or if your goal was 50, about 25 clicks. So you have to kind of keep that in mind.
Okay, very good. Okay, thank you so much, Dr. Khaimi. We might go back to you later for further questions,
Sure.
if that's okay with you. Okay, now we'll just move to the next speaker. We have Dr. Nayef AlOtaibi, who is a glaucoma consultant at King Khalid Eye Specialist Hospital, where he also had his fellowship. Dr. Nayef is really one of the best surgeons that I've ever met, and he was one of the first glaucoma division members who tried and practiced AB-IC procedure after the visit of Dr. Khaimi. Dr. Nayef is going to speak about the patient selection and surgical tip. Nayef, please go ahead.
Assalamu alaikum. Good afternoon, everybody. Let me go and share. Okay, assalamu alaikum. Good afternoon, everybody. Thank you for this introduction, Dr. Ahoud. It's my pleasure to be with you all. Speaking about EPIC, which is one of the many options of glaucoma procedure that we have, but as Dr. Khaimi explained beautifully, the advantages of EPIC that we have in our patients will give us much more options to do for further treatment or further procedures. First of all, I have no financial interest with the manufacturer or any of commercial products in this presentation. In my speak, I will talk about patient selection, and I'll present two cases. First case, in April 2018, we have this gentleman, 79 years old male with chronic liver disease, ocular history, has pseudoexudative glaucoma with SLT done about 2 years and the same year of examination. He was on timolol, preservative-free, tafloprost, and he was poorly compliant with medication, and he has allergic to the most of glaucoma drops. So in his examination, vision was 2160, improved to 2125 by pinhole in the right eye, 2160 same. Both eyes were almost the same examination, 23 IUB in the right, 20 in the left. Conjunctiva was quiet. His eye was virgin eye. No procedure was done for him. Only SLT, clear cornea, ACD with cataract in both eyes. And disc shows 0.85, almost like advanced, or 0.9 cupping in the right eye with 0.8 in the left eye. So our plan was to take him for phaco BCIOL with glaucoma surgery, either trap or tube. But luckily was the ITRACK or EPIC procedure was introduced to our institute, to KKESH, and we were waiting for Dr. Khaimi to visit and to do the first EPIC procedure. So he was lucky to be the first patient, and our plan was changed to be phaco with BCIOL and EPIC in the right eye. In this video, we show this is not the patient; it's another patient. Usually we start with phaco. This patient going for phaco emulsification with EPIC, we started with the phaco. This video was done by Dr. Adi and edited by him. Thank you for him. We go with the phaco, and as you say, with grooving, and after we implant the IOL, we fill the anterior chamber with the viscoelastic. So we widen the angle to be able to see the angle clearly and to widen it more. And usually after cataract surgery, most of the angles are wide enough to see the structures. Then after we widen fill LAC with viscoelastic, we put some of the visco over the cornea as a coupling agent for the gonio lens used. Then we introduce through another side port, directed nasally to the angle, so we can enter the catheter through this paracentesis, and it will go like in the same circumferential direction. Then we'll move the head of the patient. We'll position the patient, change the head, push patient head to be away from the surgeon and the microscope toward the surgeon. Here we are using a gonioscope, and to visualize the angle, as we said here, the angle was clear. Testing the viscoelastic flow before starting to make sure that the visco is flowing. Then with using of long needle, we create an incision at the trabecular meshwork, and we can see here, we press over the inferior lip and to see our incision or our place to introduce the ITRACK catheter. A bit of blood, we can remove it by using some of viscoelastic. Then we introduce the catheter through the SCHLEMM'S canal, and it will go like easy. If it goes easily through the SCHLEMM'S canal, that means that we are going through the canal itself and not misdirection. If there is any obstruction, we can just press over the area of illuminating, the area illuminating, or the area where the ITRACK stopped, and try again, and sometimes it will go. Here we can see where we are. If we are in doubt, we need to know always where we are, not to go misdirectly to other places. So here we can see the illuminating tip at this area, about 180 degree. So, then we will continue through canalizing SCHLEMM'S canal to reach 360 degree, and we'll see the illumination at the site of entrance. Then we'll return the head back, and we will pull the ITRACK, and as Dr. Khaimi said, start notching or clicking the injector. Usually I do like Dr. Khaimi recommended for 30, I do like 28, 20, 26, like this, like 2 clicks or 3 clicks per 1 hour or pulling. And we can see the blanching of the blood vessels here as we retract the ITRACK and injecting the viscoelastic into the SCHLEMM'S canal. So then we'll go with this microhyphema. It's not much of an issue. We can just clear the viscoelastic intracameral, and you wouldn't need to be more worried about small clot of blood at the site of entry. It will go after a few days of post-op. This is the procedure done now, and this patient, this is the end procedure. So back to our patient. After 2 years, about 2 years, in December 2019, we did the other eye after that, after April 18, by like 3 or 4 months, and last follow-up it was in December 2019, about 20 months from first surgery. Vision was 20/25 both eyes. IUB was 18/17 both eyes, no drops, and there was stable cup disc ratio and visual field. And we compare it to the previous examination. We will see that we spare him from a lot of major surgery with this minimally invasive and highly successful procedure. Luckily, he was benefited a lot of this procedure. So in patient selection, first we need to go with open angle glaucoma. We cannot do it in narrow or closed angle. Pseudoexfoliative patient with open angle will respond much better than others, as my experience in this. Mild to moderate glaucoma, as mentioned by Dr. Khaimi. Advanced glaucoma needs much more aggressive treatment and much lower target IUB. Although some of our patients had very low IUB after epic and cataract alone, we reach like low teen. And glaucoma patients who are going for cataract surgery and they are on medication, like 3 agents with mild or moderate glaucoma going for cataract surgery, why not to spare him from those medication burden and buy a time if we are going to interfere later. And this is what happened with our patient. Patients who are non-compliant with medication or have allergy, or they are not happy with their medication, this is a very good option to consider. Patient underwent or undergone a trabeculoplasty. I see them responding very well to EPIC if they have been treated with SLT. And patient with failed surgery in the fellow eye, so we can try this procedure to buy us time and before going for the much more aggressive procedures. Patient we need to avoid those with chronic angle closure, narrow angle, patient with peripheral anterior synechia, neovascular glaucoma, uveitic glaucoma, and patient with angle recession glaucoma. Those kind of patients we need to avoid them. Results are not that much of what we are looking for. As the second patient here, as Dr. Khaimi said, or as in canaloplasty or AB-INTERNO or AB-EXTERNO, first patient we tried it and we showed that AB-INTERNO was much more successful with here with this 12 months old baby girl, we tried another way of ITRACK. The idea here to show that we have ITRACK give us much more option than AB-INTERNO and more with even much more complicated glaucoma patient. With this patient, 12 years old, 12 months old baby girl, secondary glaucoma, Sturge-Weber syndrome, IUB was 21/11 in the right eye, 21/11 in the left eye. She was on full medication, Timolol, iobidine, Zola, Lumigan, every medication we have, we give it. We try to buy time to reach this age so we can operate and to give her much more chance to success in our procedure. Horizontal corneal diameter was 13.5 in the right eye, 11 in the left eye. Barometry corneal thickness was 637 in the right, 560 in the left eye. Left eye was normal eye. Lid in the right eye was, it has port wine stain, vascularized conch, large, clear cornea, AC deep, iris normal, and cup disc ratio was 0.8. Left eye was normal and cup disc ratio was 0.3. The plan was to go for, here in Saudi, we go for deep sclerectomy in childs or congenital glaucoma, and in secondary developmental glaucoma, secondary congenital glaucoma. We started with deep sclerectomy. And with this girl, because of the Sturge-Weber and the advance and difficulty of Sturge-Weber syndrome and high chance of failure, our plan was to go for deep sclerectomy with AB-INTERNO canaloplasty, same as AB-INTERNO but external. In this video here, we showed that after the second flap, we go and we just wet the area a little bit. We are testing the viscoelastic flow as we do in AB-INTERNO, and we go through the AB-external canalization. We canalize AB-externally here, as we said. The problem here is it is dangerous that we open the window, but we need to be careful not to open the window with this kind of patients, Sturge-Weber patient. So we canalized 360, as we see here, the whole angle. Luckily, the angle or SCHLEMM'S canal was patent 360, so we reached 360 canalization. And same as INTRASCLERAL, when we pull the catheter, here is the tip of the ITRACK. And this is the beauty of ITRACK. We can use it AB-INTERNO, AB-external, and it will give us option to treat our patient at the time we need more or increase the chance of success. Here now we start injecting, as we said here, as we see here, yeah, I think this is the end of the video. So in between AB-INTERNO and AB-external, here the patient after 1 month post-op, IOP was 13, BITONO it was 21, quiet, conjunctiva was quiet, blip formed and everything is fine, fundus was within normal and with good red reflex, and we hope to see her soon and to see how's our result. Between AB-INTERNO and AB-external, as was shown by Dr. Khaimi, AB-INTERNO, I'll use it in mild to moderate glaucoma, while AB-external, I'll use it in advanced glaucoma. The beauty of AB-INTERNO or ABIC, we spare conjunctiva and can be standalone procedure or with cataract surgery. AB-external, it needs conjunctiva incision with sclera flap. If I'm going to use AB-external in canaloplasty, I would do it together with another glaucoma procedure. I will not do it alone. Although we can do it alone. It can be standalone procedure, but still, if I'm going to incise the conj and do sclera flap, I'll do the glaucoma procedure plus AB-external canaloplasty. I hope it was informative for you, and thank you very much.
Thank you so much, Dr. Nayef. Excellent presentation and very nice videos there. So I'll just go back to your first patient. So you achieved a pressure of high teens. And with that, you know, advanced cupping, do you think this is a good target pressure for that patient?
Yeah, because he was not using the medication. He was refusing the medication. He was always allergic to medication and not non-compliant at all. So we followed his visual field, his cup disc ratio, and it was always, since the procedure we did, it was always stable. We are following him closely. That because of this high teen and this cup disc ratio, yes, we may go. In our target, I would like to be like 15 or below, but with this patient in particular, because he's an old gentleman, he's not that much old, but he doesn't like drops. He's not compliant, allergic to many kinds of drops. So we are following him closely with the visual field and cup disc ratio, and still, since then, he is still stable.
Okay.
I wish him much more better IOB, but yes, we can follow him if we follow him closely. If we notice any increase in intraocular pressure or any changes in visual field or in cup disc ratio, yes, I'll start him on medication.
Okay, excellent. My second question, what kind or what size of needle do you use for your goniotomy? Which
Yeah,
size do you use?
Yeah, we use 25 long needle.
Okay.
Yeah, 25. Yeah, it is long needle or MVR. But I prefer 25 needle. It's available everywhere and easy to be used. Sometimes we can connect it to viscoelastic. At the time we do our incision, we inject viscoelastic at the same time, so we clear some of the hyphema which might obscure the area of incision.
Mm-hmm. Because I know some people, they are using the 27 and they also use the 27 to create the paracentesis, which makes, I think it makes sense because it gives you a more, you know, controllable and more precise incision. Yeah. So when you insert the catheter, it will be stable.
Our paracentesis or side paracentesis, or the additional paracentesis, it's small one. We are not going to open that much of paracentesis. It's just the tip of super sharp we're using, not the big openings. Other thing, the AC will be maintained by viscoelastic. The whole procedure. If you notice at any time the AC collapses or there is shallowing of AC, we will it's better to reform an AC again to keep an eye on AC at the same time.
Okay, and
yeah,
we
it's
have
a good idea to use the 27. Yeah, I agree.
Yeah, and we have Dr. Isam Uthman from the King Saudi University. He's asking about the trabecular cut by the needle. Is it horizontal or vertical?
I didn't get you.
The trabecular cut by the needle. Is it horizontal?
Yeah, you mean
or
the opening? I go horizontal. Yeah, I go horizontal. Not
Okay.
No, I go horizontal, like small slit, and depress the inferior lip, the posterior lip, so we can see the area opening. And sometimes if we see like whitening at the tip, that means you are in the right position.
Okay, thank you so much.
Yeah, it's not vertical or horizontal. Yes.
Okay. Any different thoughts, Dr. Khaimi or Dr. Konrad? Adi?
Yeah, I mean, I think a lot of good points by Dr. Nayef. I think I tend to like to use a 1.0 side port blade for my paracentesis because the 27 gauge can sometimes be too constrictive, and it may make it a little bit more difficult to feed the ITRACK catheter. Of course, for the beginner, I think once you're very comfortable and you don't shy away from a procedure because it's not working out like you want it to work out initially, then you can use a 27 gauge. I don't think there's a problem. And we use a 27 half-inch needle only because the longer needles, we noticed there was too much flexion in the needle. We didn't get that sturdiness in the half, like we did with a half-inch needle. And yes, it is a horizontal score, just like Dr. Nayef beautifully showed in his video, a horizontal score and then pull down so that you can see the opening there.
Okay. And do you recommend using a second instrument to stabilize the catheter while pulling it out?
I mean, if you have to, you have to use it, sure, I think, so that you don't, the goal is not to create an otomy here, right? The goal is to maintain trabecular meshwork and Schlemm's canal. So my technique is such that I don't tilt the patient's head back towards me. I keep it tilted away from me, and I keep the gonial prism on top of the cornea, pushing down. And then I withdraw the ITRACK catheter out the same direction that I put it in. Typically, that doesn't lead to extension of my otomy side. Yeah. But if the otomy is extended, it's at that point that I'll either put the MST forceps back into the eye and feed it out backwards, or you can take a second instrument like you mentioned and use it as a fulcrum so that you don't extend your otomy.
Yeah. Oh,
all techniques are doable.
Yeah.
The other thing we can what is it in the sideboard we can make it a little bit not nasally exactly. Can I share one? So here, like
maybe more oblique, you mean, Dr. Nayef?
Yeah, maybe like in here. I think this will give us much more. So yeah. Like in here will make it much more oblique to this way. So the catheter will go like here from there. So when we pull it, it will not go here. It will end by this angle.
Yeah.
But if we go like a bit oblique towards the nasal side, I notice it's a bit, yeah. At least this is what I notice in our patients, in my patients.
Yeah, that makes sense. Oh, okay, thank you so much again, Dr. Nayef. We'll just move to the third speaker. We have Dr. Konrad Schargel, who's a glaucoma consultant at King Khalid Eye Specialist Hospital since 2018. Dr. Schargel had a fellowship in glaucoma, retina, and anterior segment. And he's the ex-head of glaucoma and anterior segment, ocular trauma and neuro-ophthalmology section at the University Hospital of Trayeva, Alicante, Spain. And he had a long experience in MIGS. And today he's gonna speak about the AB for ABIC in dummies. So very interesting. Please go ahead, Dr. Konrad.
Thank you, Dr. AlOwaifeer, for this kind presentation. I'm gonna share this, and here we are. Okay, well, basically what I thought when you proposed me this talk is, okay, everyone is gonna present the cases and results, and Dr. Khaimi is an expert in this. So what can I give also to this webinar? Well, basically 80% of my time here at KCASH, I'm teaching fellows and residents, which I feel proud of doing that. They are excellent people. And I will tell one anecdote. One of my fellows, these two were working together. One of my fellows started the procedure, and after having some difficulties, and the surgery at the end came out good, he told me, well, in YouTube looks easier. And it's true. When you get into YouTube, you find everything from doing a pizza or a Spanish sauce to Arabic. And what I thought is, based on these popular books on things for dummies, let's talk about the tips to improve the Arabic. If someone is new, there is a lot of residents attending now. So to start with the understanding of the Arabic, since the paper of Johnston and all the mixed surgeries that we have started, we now know that the Schlemm canal and all these collecting channels are very important that we probably thought before. And we are having a real understanding of all of this. And Arabic comes from the viscocanalostomy and canaloplasty. And all of us that we are deep sclerectomy surgeons and we have been practicing since long time, for us was easier to work in this kind of technique from the sternum. But the brilliant idea of Dr. Khaimi and also Dr. Gallardo, that were the first one, I think, that popularized this, was why not doing inside, preserving the conch for future surgery. So the Arabic is the next evolution of all these ab-sterno surgeries. One of the first papers that I want to show is the comparison between surgeries done ab-sterno and ab-interno in the same patient, different eyes. And Dr. Gallardo had exactly the same IOP at the end of the procedure with the same amount of medication at 1 year of follow-up. Also, as Dr. Khaimi showed, very nice. If it's combined with phaco or as a standalone procedure, there is mainly not pressure difference. And maybe the only difference that Dr. Gallardo showed in this paper is only in the number of medication. If it's combined the Arabic with the phaco, it seems that patients at 1 year will need less medication. Some explanation that can be given is that according to this paper of Rubinstein, there is an increase in the cross section and the Schlemm canal volume in normal patients that goes under phaco only. That increase in volumes and size is about 25%, but there is no modification in the pressure. So we need to do something else in the Schlemm canal, and that is the key point on combining with the viscodistension, and probably the explanation why this works so well. These are my results at 6 months here at KCASH, and in a very limited number of patients. Here is mixed, the ones that I have been as a main surgeon or assisting my fellows in doing it. But the level of pressure that I obtaining at 6 months is not bad. It's 13 as an average, and the number of medication at that time is also good. So among all the surgeries we have, and my steps for the 2020 right now are about here, the great advantage of all angular surgery, and one of my favorite is the Arabic, is that we are really preserving the conch for further surgery. Some of our glaucomas are really aggressive, so we know that we will have to do something later on. But if we can delay that, as Dr. Khaimi also said, it will be much better. So prognostic factors here. We know that this is not a technique for pressures that are very high. It's better in patients that has pressures below 30. And one of the most important things for prognostic, as a prognostic factor, is the reflux that the Schlemm canal will have in case that is after the decompression. That could be related to the phacoemulsification or not. But according to that reflux, we are gonna have a better outcome or not. Also, Dr. Grieshaber talked about doing a canalography, injecting viscoelast furosemide, but I don't think that is something that is useful. I think that is more useful just to observe the reflux of the Schlemm canal after the end of the procedure. So back to the key points, tips to start. Well, I'm gonna talk about these 4 points. First thing, we all have saying how are our best patient for the ideal patient for Arabic. For me, will be a mild to moderate open-angle glaucoma, pseudosfoliative pigmentary glaucoma. I will prefer to use it in younger patients. I believe that older patients will have some collapsing and sclerosis of the collecting channel and Schlemm's canal, and probably it's not going to work that better. I will prefer to do it in patients that have pressures lower than 30, and that my target pressure will be around 14 or 16. It could be done in pseudophakia or patients without cataract, or patients that are going to go for cataract surgery, patients that have side effect or surface problems or issues with the compliance of the medication. Angle should be open. It could be a little bit narrower, but when we remove the cataract, the angle should be open and we should have a clear view. And of course, with the good reflex of the blood in the Schlemm's canal, and of course, no synechias there. Second point, to start the surgery, this is for the beginners. Organize everything. Everything should be near you. Everything should be in the room. And important thing is prepare, mount all the equipment. As Dr. Khaimi said, we don't need a lot of things here, even if you see this table full of instruments, but we don't need much. But the important thing is that everything we are going to use, it should be first tested outside. The probe must be pushed outside. We have to get the time to look properly to the angle. And here I have to get the chance to say thanks to all the OR staff at KCASH, because they make every surgery easy and all the videos good too. So purging the probe outside, it's very important. As you can see, my good fellow, Dr. Abdullah Ben Hameen, is going very fast, trying to get the viscoelastic out of the probe. This has to be tested outside because there are problems that can be related to the movement of the viscoelastic, and you have to be totally sure that before starting everything works properly. Once you got that equipment ready, get the time to observe the angle, fulfill the anterior chamber with the viscoelastic, and do the third incision and go for the Schlemm's incision. And this is how I planned the incision. That's why I didn't want to answer the question you asked, Dr. Ovaida, because this is the way I organize it. If all of my 12 cases done here at KCASH and the previous one done in Spain, all of them were combined with cataract surgery. So none were as a standalone procedure, but basically this is how I made the incisions. And answering now that question, I like to use the NVR. And basically I like to use the NVR 20G for one reason. I think that we have to try to maximize the use of the instruments, and I don't like to have a lot of knife on the table. I try to use the NVR for the second instrument, for the main incision for the catheter, and I use the keratome for the main incision. And the same NVR 20G is the one that I use for doing the Schlemm's canal incision. So look for the angular structures. This is very important. The position of the microscope, you have to feel comfortable with it. Position of the patient, tilt the head away of you so you will have a better view of the angle. This is what we do with all angular surgeries. And which lens you can use? You can use any lens that you feel comfortable. The most popular is the Schwab-Jacobs. I think that that one it works very good. But you have the Quan, which has a support ring like the Thornton ring mounted in the same one, so you can move the eye if you need. And you also have the indirect lens or Mori lens that you can use it for it. Well, this is the procedure. I think that the cataract goes a little bit fast. Yes. Anyways, combined with cataract, this is the incision I do. I like to lower, as Dr. Khaimi said, I use the viscoelastic, and once I put the catheter inside, I think that fixated at the cheek or at the forehead, according to which eye you are doing, you have to be sure that you have enough catheter to move freely with the movements once you are inside of the eye. Really, in most of the cases, if you don't find any obstruction inside of the Schlemm canal, it goes smooth. And I like to give the order to the assistants to remove, to do the clicks. It's not they saying the clicks, I'm the one that's saying, go ahead, and they do a click and I withdraw the catheter. In that way, I have the control of the movement of the catheter. And I know that by doing a click, the administration of the viscoelastic will be basically the same. What to do in cases in which you don't have a good vision? Well, as we were talking, the good blood reflux, it's a good sign, it's a good prognostic sign, but it also can make a little bit difficult vision of the introduction of the catheter. And if you start having this messy with blood, the first and easier way is applying more viscoelastic, but other way, you can use the irrigation aspiration probe and clean all the blood out of the way. The important thing is that you keep a full vision during the whole procedure. We have to really be in absolute control of what we are doing. Complications, as Dr. Khaimi showed, are very, very low, but it can happen. So the important thing is if you master the technique by keeping the vision, good vision in all moments, that will be good. In summary, prognostic factor for my ABICs, I probably can extend to all angular surgeries, are distal exit routes should be intact or working good. You can evaluate that with the blood reflex. The level of intraocular pressure, I think, is important. You have to be sure which pressure the patient has previously and what is your target pressure. This will not be like a trap or a DS. You're not going to get 10 millimeters of mercury if that is your target pressure, but you are going to get a very good pressure if the state of the patient deserves that level, halas. If not, you probably have to think in another surgery. And the good point here is that you are preserving the conch for further surgeries. ABIC absolutely is the next evolution of SCHLEMM'S surgeries. We have to really, really thank Dr. Khaimi for this excellent procedure. And tip to the people that wants to start is work with the team, explain what you need. Everything should be ready before starting the surgery. And once you are doing it, it's very important that you keep always a good vision of what you are doing. And you always have the time to stop and reevaluate. Well, this is the team of the glaucoma division. I'm really proud to work with all of them. And thank you very much.
Thank you so much, Dr. Konrad. You have excellent editing and production for your videos. You should share with us the person doing this for you.
Well, yes.
You do it yourself?
The edition, I did it myself, yes. The recording belongs to all this marvelous MTV team that we have. They are the ones that when you say this is for a webinar, they come, they check, they are sure that you focus properly and you have the right amount of light. Once the production is good, then editing a video is very easy.
So big thanks to all of them. So
yes.
Dr. Konrad, do you have any like different or specific protocol for the post-op, medications that you use?
Well, as Dr. Khaimi said, I like, the steroids regime. It's basically the same one that we use for the cataract. The antibiotic is also the same. And I don't like to start medication for IOP control right away. I prefer to observe and see how is the response. It's true that I like to wash out all the viscoelastic right after the procedure, and most of the blood, I haven't found any hyphema after that. You can have like some hematic cells floating in the anterior chamber the next day, but not a real hyphema. And according to how is the response and the severity of the disease is when I add the IOP medication. But I usually, in most of the cases that I have, right after the surgery, none of them need medication. And in the follow-up of 1 month is when I add 1 drop if they need. So I'm really, really happy with the results and the outcomes we are having with this procedure, yes.
Okay. And have you ever, had any complication, or let me say difficulty during the beginning of the procedure at which you had to convert or stop or,
Yeah, well,
defer the procedure?
no, not that I have changed the procedure, but when I start thinking about this, it was, in a way, it was funny because Abdella was starting the procedure and we really did not prepare everything. And we started, with the eye prepared, but the probe was not ready and we couldn't get it in the point, but not serious complications. I mean, this is a procedure that once you have everything ready, I think it goes very smooth if you select the proper case and you have
Yes.
time to evaluate it right before starting. So I do the cataract, I evaluate the angle, and then I say, okay, this is a good eye for this surgery or that surgery. And once I decide, then I go for it.
Okay. Okay. So thank you so much, Dr. Konrad. We'll just move to the last but not least speaker, Dr. Adi AlOwaifeer. Dr. Adi is the Assistant Professor of Ophthalmology at College of Medicine, King Faisal University at Al Ahsa. Dr. Adi completed his residency and fellowship at Riyadh, at which he was the Chief Fellow of 2019 and 2020 batch. And we were glad to have him as a fellow and one of the best fellows at glaucoma division. Adi is going to present the K-CASH results of ABIC. Please go ahead, Adi.
Thank you very much, Dr. Awaida, and I'd like to thank all the speakers. It's difficult to follow such great speakers and mentors. I've learned a lot about ABIC from Dr. Khaimi when he visited K-CASH back in 2018. And as well as from my mentor, Dr. Nayef AlOtaibi, whom I did most of the cases that I'm going to present today with him. So what I'm going to do is I'm going to present our experience here at K-CASH with the first year of ABIC cases that we did after Dr. Khaimi came to us. After all, this is a process of ensuring the quality of care we deliver to our patients. If this procedure worked somewhere else in the world, it may not work as good in our patients. That's the question we raised, and that's the question what we aim to answer in this review. So I'm going to share with you the results of ABIC that was performed either as a standalone procedure or combined with phaco in patients with glaucoma done at K-CASH. So it was basically a retrospective chart review of adult patients that underwent ABIC with or without phaco during the period from April up until December 2018. And we excluded patients that had less than 6 months of postoperative follow-up. And just to find out in which patients we had the complete success and which patients were partially successful, we defined success according to the World Glaucoma guidelines of definitions of success, where complete success where if the patient had IOP between 5 and 21 without medications and qualified if it was with the use of medications, and failure was defined when patient needed additional surgery or progressed to no light perception. So in that year, we performed phaco ABIC with or without phaco in 15 patients, 13 males and 2 females. And the age range was between 27 and 87 years. We had a range of glaucoma diagnoses, some were open angle, some were pseudoexfoliation. We had 2 eyes with uveitic glaucoma, though those were not active uveitic glaucoma patients, but they had past history of uveitis that was quiet at the time of presentation, and they had glaucoma that was most likely secondary to chronic steroid use. That's why we thought that ABIC would be useful in such patients. We had a wide range of glaucoma severity. 6 patients were mild, 3 were moderate, and 6 were severe. And I know that we've been talking about MIGS in general are only suitable in patients with mild to moderate disease, but I guess that we were challenging the procedure itself, where I remember when we had a patient that had advanced glaucoma but had cataract and the pressure was either high teens or early 20s on 2 or 3 medications, we would plan ABIC as a adjunct to phaco, since the patient is already going to cataract surgery and he doesn't have that high IOP that would necessitate a filtration procedure or a tube surgery. So those are our indices at baseline. The mean IOP at baseline was 18 millimeters of mercury, and the mean number of medications used was 2.5 medication. This is a summary of the operative findings. Most of the patients, so 14 patients, had phaco combined with ABIC, and only 1 patient had standalone ABIC. I just wanted to break down the patients by the extent of ABIC. I know, optimally speaking, you need to cannulate the SCHLEMM'S canal 360 degrees, but I think it was part of the learning curve. In the first few cases, we were not unable to cannulate the canal completely, and we would stop at 180 or 270, sometimes due to resistance, and in other instances, we sometimes see the catheter itself, rather than continuing circumferentially, going to the suprachoroidal space, so we would stop at that. So this figure shows the behavior of IOP over time. As I mentioned earlier, we started at 18 millimeters of mercury, and the IOP at 9 months of follow-up dropped down to 13 millimeters of mercury, and this difference was statistically significant. And the more important finding is that the mean number of medications used dropped from 2.5 medication down to 0.9 medications at 9 months, and this difference between pre-op and post-op values was also statistically significant. We always talk about reducing medication burden and improving the patient's quality of life, and in our review of 15 patients, we had 7 patients that had complete success and were medication free, and another 7 patients that had qualified success and needed glaucoma drops to control their pressure. One of those patients failed and required a further surgery. It was actually a juvenile glaucoma patient. He was 27 years old. Probably ABIC was not a good choice for him, as Dr. Konrad was mentioning earlier. Properly select your patients. We thought to try ABIC in this patient because on examination his angle looked normal as an angle of an primary open angle glaucoma patient, but probably he had some sort of dysgenesis in his angle that led to failure in his case. And in his case, the failure was actually early post-op, and he needed a deep sclerectomy to control his pressure. Complications, we had in 4 instances microhyphema, a faint layer of hyphema that resolved without need of any washout or further intervention. And again, I think this is partly due to the learning curve. As you're learning during your first couple of cases, more manipulation is needed, and therefore more hyphema is induced. We had 1 patient that had an IOP spike that in the first week post-op, pressure was above 30, but soon came back to normal levels after starting glaucoma medications. And in 1 instance, we had a patient that had a choroidal effusion. It was a mild choroidal effusion, maybe due to lowering of IOP intraoperatively, but it resolved with medical management completely. So just to give a quick comparison, ABIC probably lacks randomized prospective data in the literature, but you can find plenty of retrospective reports by Dr. Gallardo and others. And in our case, we've got a success rate of 93% compared to 77% in Davids et al.'s report. And in other cases, they did not report success rates, but looking at drop in mean IOP, we can see that in all studies, IOP drops from a range of 20 or high teens up down to until low teens in all published reports. So in conclusion, given our trial on this small group of patients, we can say that in our patients, ABIC was effective in achieving short-term control of IOP in patients with open-angle glaucoma. And we've got about half patients that were medication-free and achieved complete success. And the procedure is, of course, safe, and the reported complications are transient and visually significant. And I guess the next step for ABIC, as we were talking about at the beginning of this webinar, is probably to compare it against GAT. So a randomized controlled trial, prospective data comparing both procedures head-to-head would probably be useful in outlining the safety of ABIC probably against GAT, since it's a less destructive procedure. And another point to mention, at least from our perspective here in Saudi Arabia, if you compare the cost of ABIC to other mixed procedures such as the eye stent, ABIC the ITRACK itself is cheaper compared to the cost of the eye stent. So this is another factor that I put into consideration when I'm operating on a patient that has cataract and open angle glaucoma, and I'm going to choose a mixed procedure for him. So that's it for my talk. Thank you for listening.
Thank you so much, Dr. Adi. Excellent presentation as usual. So we'll just go back to that only patient who had a spike of high IOP. So have you had to stop his anti-glaucoma medication after the surgery, or he was already on his drops?
No, he was actually off medications.
Completely off?
Yes. In all our patients, after the ABIC procedure, we stop all the medications. And some patients you'd like to wait, as speakers earlier mentioned, you want to wait for a month to see the exact effect of your procedure. But in his case, he had advanced glaucoma, and we were not comfortable keeping him on a pressure of above 30 for a couple of weeks. That's why we reinstituted medications. So
do you recommend keeping the anti-glaucoma medications even after the surgery for certain patients? For example, that patient with an advanced cupping?
Well, as long as you are going to see the patient, there's no harm in stopping all medications and seeing the effect of your surgery. Typically, we see the patient 1 day post-op and then a week post-op as well. So if you're going to follow the patient on this interval or this time frame, there's no harm in stopping the medication, even if he has advanced disease.
And how frequent you follow up the patient usually?
And the 15 cases that I've illustrated, the time frames that we went through are 1 week and then 1 month, and then 3 months, 6 months, and then 9 months. After 6 months, if everything is okay, it's probably not necessary to bring the patient 3 months afterwards at the 9-month interval. But we were planning to follow those cases. That's why we were bringing the patients every 3 months, just to see our results in the first couple of cases. But in routine care, if at 6 months everything is fine, you can see him at 12 months. I don't think there's any harm in that.
Okay. You had a comment on the lack of prospective data of the APIC comparing to the other mixed procedures. So I'll just transfer this point as a question to Dr. Khaimi. Dr. Khaimi? Yep.
Yeah, I think ideally the best kind of data that you can get is a randomized prospective study. And so currently right now at the Dean McGee, we're actually going to start a prospective head-to-head with ABIC versus Hydrus, as a matter of fact. Retrospective studies, there's quite a bit of them, as we've mentioned before, that show good data. But I think in a ideal scenario, prospective studies would put a little bit more emphasis on how good the data is. The issue with that is they tend to be very time-consuming, long, and quite a few patients have to be enrolled. We're at a tertiary center where most of our referral basis comes in for a select procedure, and then we release them. So just the complexities of doing prospective studies in itself is somewhat of a hamper, but I agree. I think prospective study is what is the only lacking thing right now that we need, in addition to our retrospective studies, for sure. And I would actually implore others who now have seen good data with the ITRACK ABIC to begin doing their own prospective studies, and so that we can get, the more data we can get out there, whether it's retrospective or prospective, the better it is for the procedure. And for us to actually identify, what is a true legitimate procedure versus a procedure that may not do well for a patient or a patient category.
And maybe in future we can do a collaborative data between our center and your center.
Oh, that would be great.
Yeah.
I have no issues with that. The high level quality of talks and studies that preliminarily that you guys have put out shows me that we would be a great fit together, and I think that would be very much welcomed.
Thank you so much, Dr. Khaimi. So we'll just go for the final remarks. Dr. Konrad, anything you like to add?
I think that we have said mainly everything. It's a procedure that has very low rate of complication. It worked very good. Especially the key points here will be selecting properly the patients. We have to add as most of the technique in which patients this is going to work according to the target pressure we are expecting, and basically train the people around you on these techniques. But we have to think that we have an available technique. I won't say easy, because I don't believe that surgery is easy, but it's something that is quite manageable. Yeah.
Okay, thank you, Dr. Nayef.
Yeah, I think as Dr. Konrad said, we've almost said everything, but I think lately in glaucoma we have a lot of options as choosing the right procedure for the right patient is the most important thing that we need to look at carefully. This is the thing. All procedures, I think, which was not working in one patient, the other procedure will work though. With this kind of options we have, thank God, now we have a lot of options. Before we only have one or two options, now we have a lot. So patient selection and procedure is the most important thing.
Yeah, I think we're in the luxury era in glaucoma surgeries right now. We have so many different procedures, and I think those varieties and
we lost Dr.
are attracting more fellows and to join our division for training, because they can do a lot of those. Yeah, I totally agree. Dr. Adi, anything you like to add?
The only thing that I'd like to mention is that for those people that are anywhere in the world that still don't believe in ABIC, we need strong prospective data to convince them. So looking forward to the results of the trial that Dr. Khaimi is going to do, comparing ABIC against Hydrus. And to be fair, for ABIC, I think it still needs to be compared prospectively against other mixed procedures, so that we can convince, so that the data becomes convincing to more people out there.
Totally agree, Adi. Thank you so much again. And our respected guest, Dr. Khaimi.
Thank you. Yeah, I mean, I really appreciate the opportunity to collaborate again with you guys. It's exciting that it seems like ITRACK ABIC is gaining traction in Saudi and in other parts of the world. I think Dr. Konrad mentioned that he did it previously at his former location prior to coming to Saudi. So yeah, I think it's just a matter of time. And I think, no matter how much Khaimi says the data looks great and everything. I think you need to do it yourself. And I think you need to do it on your patient patient profile. And I think you actually, and what I teach residents and fellows all the time, actually analyze your data. So don't go by anecdotal data. Actually analyze the data in itself, and you'll be surprised to see what you find. And I think that's very important.
Yeah, totally agree with you, Doctor. So thank you so much, Doctor. It was a great pleasure and honor time in KCASH in future, inshallah. Thank you all for all the speakers, Dr. Konrad Schargel, Dr. Nayef AlOtaibi, Dr. ALOwaifeer. Thanks also to Al-Basar Company for their excellent collaboration to make this webinar live. And thanks to all the attendees, and sorry for all those questions that we couldn't answer. Thank you all. Please stay safe and take care. Thank you.
Thank you very much.
Thank you.